Good evening, everybody. I'm hoping you can hear me okay. My name's Brendan McGrath. I'm an intensive care consultant in Manchester in the UK, and I've been working with the Global Trachea Collaborative since about 2012 now. And I've been asked to talk about our experiences in the UK of making quality improvement work. For the webinar, because it's a little bit late at night over in the UK, we're going to do things slightly differently. So I'm going to talk about how we do things at local level, sort of on your unit, how we do things at the hospital level, how we do things in your country, and then talk about some of the work that we've done with the GTC internationally. It's about 10 at night here, and then evening time in the US and early morning in Australia. So how we're going to play this is you've got me talking and some of my guests that I've pre-recorded rather than make them come out late at night. There's you, the community, watching, and you can leave us live questions. We can have a interactive discussion while the webinar is going on. So if you're watching this live, these are the options that we've got. We're going to record this webinar and we will show it again to anyone that wants to have another look on the website. So if you're watching it later, or if you've watched this webinar live and you want to follow up with us, there'll be some discussions on the GTC website. Some of the issues that we highlight, of course, there'll be peer support from other members and contributors to the collaborative, and the resources that I talk about will be available for you to look at later. So I've asked a few people to contribute to the webinar. On your screen there is Professor Julian Bion, who has been very helpful in the UK in advising us about getting quality improvements established through some of the programs that we're running. I need to thank Julian for borrowing some of his slides as well. On the opposite side of the screen is Dr. John Crampton, who's the medical director at the hospital I work in. He's going to share some insights. Below Julian, who's got the bow tie, is James Lynch, who's one of the charge nurses and project managers at our hospital down in South Manchester, who's been running tracheostomy quality improvements in the UK for a number of years now. And Bob and Christine Sutcliffe are our patients and family representatives who will be giving us some of their insights into quality improvement from a patient and family perspective. So starting things off, thinking about your unit. So you've got an idea that you want to improve care. What are the sort of things that you need to think about? So firstly, why we're doing this? Well, you've taken the time to look at this webinar, so there is some motivation for you there. But you've got to think, you know, what is the motivation for you? What is the motivation for your department to start working on quality improvement and start thinking about some of these things that you want to do locally on your unit? You've got to try and understand what the problem is that you're trying to fix, and improving tracheostomy care is quite a difficult thing to get your head around. What are the elements of the problem that you're trying to address? What's the evidence for the problem? And we'll touch on some of that evidence today, sort of trying to understand the nature of the problem at national level, at international level, but I think it's relevant to bring it right back down to what the problems are on your particular unit. Understanding what your current practice is also really important, and when we started trying to improve care at our hospital, we realised that actually there was lots of pockets of people around the hospital that were doing things very well, but our practice was completely different from one end of the hospital to the other sometimes. Got to understand what the interventions are, what interventions you're going to try and do at your hospital, trying to work out, will those interventions have an impact, and how will they affect care? And one of the things we'll talk about this evening is how you get that multidisciplinary engagement from all the different members of the multidisciplinary team, because it's very much a team game, and that's something that we've very much realised through some of the work we've been doing here. And I've asked John and Julian to give their insights into how we get the hospital, the place you're working in, to support the work that you're doing. So the first of my virtual guests is James, who's familiar to certainly those of you that work in the UK. Some of you in the States will have met James, as well as some of the Aussies who've been over to some of the meetings. So James works as a charge nurse on our ICU in South Manchester, and he's currently project managing our quality improvement programme along with Barry Coe in the UK. And I've asked James a few questions about how we got things going on the ICU at Wythenshawe. So James is going to give us his insights.
So I think we've seen a number of patient safety incidents, recent ones and ones that we've picked up through going through on databases. Most of those, when you track them and do the root cause analysis, they were preventable harm, and we felt that by improving things, we might be able to improve patient safety and hopefully patient experience as well in the long run. So from a technical point of view, then there was a few, not so much skills issue, but the staff didn't always have confidence when looking after tracheostomy patients. We felt there was probably a training need that might improve that. And potentially some of that was causing some of these issues. Staff were less likely to fully look after patients in the way that they might if they were more competent. So from a non-technical point of view, there was a culture change that maybe needed to occur where tracheostomy care was seen as important, particularly the basic care done well to prevent these incidents from happening in the first place, and involved in the multidisciplinary team so that we weren't all working separately. And so the MDT, we're all doing the same work that they do now, but doing it quite separately and not necessarily talking to each other as much as they could. So we found that by bringing them together, we were doing the same work, but doing it a little more efficiently and saving ourselves time, and certainly saving ourselves time in talking to each other separately. We weren't having to do that anymore. We could bring it all to one forum. I think once we got started, some of the early data was particularly positive, and that helped motivate the whole team into delivering our shared goals and objectives.
So just picking up on some of those points that James brought up there, some of those practical issues with starting some of that local work is trying to characterise what your problems are. And there's plenty of data out there looking at sort of country, national level data from the UK, certainly from the US, and some of the Australasian data will tell you what the problems are in your country. But it can seem a little bit impersonal, so trying to understand what your problems are on your unit. And if you're trying to engender change locally, telling people what my issues are in Manchester or what the issues are in Texas is not going to resonate as strongly as what the problems are on the ground. And James alluded to some of those technical and non-technical elements, which we'll come back to in a minute. Who owns the problem can be a really tricky challenge, and certainly historically in critical care in this country over the last sort of 20-25 years, we've been generating tracheostomy patients through some of the successes on intensive care. But when patients leave intensive care, ownership of those patients can be problematic. And so trying to establish whose role it is to actually look after those patients needs to be very clearly established. And we were finding patients were sort of, we have a phrase in the UK, falling between two stools. So it wasn't ENT's responsibility, it wasn't intensive care's responsibility, the medical departments perhaps hadn't been involved in the patient's care. And so trying to work out at your hospital whose problem it is really important. What interventions are you going to try and employ, and what are your priorities in implementing those interventions? And that's stemming from some of the work that we're doing in the UK at the moment, that there may be a pick list of 20 things that you can choose from looking at other hospitals around the world who are trying to improve care, but there's no point spending all of your energy deciding you want to do this one thing that actually no one's interested in, and you're going to run out of steam, run out of energy. You need to look at some of these easy wins and work out what priority you should be doing these things in. And of course, you need to know what success is going to look like. So having an unrealistic goal of eliminating harm or reducing length of stay down to 3 days instead of 10 days, is completely unrealistic. So you need to choose an achievable goal, something that's relevant and meaningful to the program that you're trying to follow, and something that lets you tackle things in a stepwise, manageable approach. Data is really important here, and we'll come back to talk about data, but who's putting in the data and how they're going to put it in is, again, something you need to think about very early on when you're trying to get to grips with these quality improvement programs. So next, sort of think about beyond your unit. How do you try and influence things at a hospital level? And I must thank my daughter there, who was showing me how to insert smiley faces into PowerPoint, and I've obviously forgotten to take that out, so sorry about that. We've learned a lot about how we do things at hospital level from other quality improvement programs. And something for me as an intensivist to reflect back on is the Keystone Matching Michigan programs around central line care. And central line is something we use a lot in intensive care and other places around the hospital. But we learned a lot about the science of safety, learning from incidents and learning from errors, things about teamwork, communication, and how hospital managers could partner effectively with clinicians to make things happen and to improve care. Behaviour change is a complicated business, and again I'll thank Julian Beyond for some of these slides. Behaviour is influenced by lots of different things, and you can see here we've got capability, opportunity, and the motivation of various individuals. They're influenced in turn by lots of other factors, which again are influenced by other factors, some of which are down to the individual, some of which are down to the systems in which we work in. But you can see that if you have got an organisation that makes patient care and patient safety a normal operating characteristic of that organisation, if the environment that you work in is supportive and allows you to demonstrate some of those sort of personal skills, knowledge and abilities, to sort of let your capabilities loose on trying to influence behaviour. All of these factors need to come together when you're choosing your team, choosing the environment, and choosing the way in which you're going to try and engender change in your hospital. There's lots of ways of looking at this, and we'll make these references available at the end, but theory of quality improvement, the theory of change management, there's quite a lot of literature about it. And I think importantly for a group like the Global Trachea Collaborative, we're very fortunate to have people with a lot of experience of making things happen, making changes in the hospital, people who've done things very well, people who've come up against obstacles, and one of the key resources we have in the collaborative is each other. And that's something that I know that certainly in the UK we've been sharing a lot of information with each other about how to make things happen. One of the keystones of any quality improvement program is multiple plan, do, study, act rounds, and not everything you choose to do will go well. It's to be expected that you will choose to do some things that don't get off the ground. When you do them, you realise that wasn't quite what you had in mind. But plan, do, study, act cycles are really important, and obviously you should follow them until you're either dizzy or you feel sick or something good happens. Social signalling is really important, and you can see here this example where there's three people who decide to cover up their face and just show their eyes, and clearly that's for three completely different reasons. But when you're trying to signal your intentions around trying to make changes happen, around quality improvement, it's really important. And if we take that middle example where someone's put on a mask and we apply it to this setting, it's pretty clear that this team of people have come together. We all know that the evidence for wearing masks in theatres to try and reduce infection is a little bit flimsy, but we know that these three people in this photograph are making an effort, and they're telling each other that they're making an effort, and the whole team in that theatre knows that everyone's doing their best to try and reduce the chance of infection for that patient and to try and make a difference. And so social signalling and putting a team together can really be important when you're trying to get these things off the ground at a hospital level. This is the first tracheostomy team ward rounds that we did at our hospital a couple of years ago now. I think I had a little bit more hair then, and I'm sure the other members of the team will be cringing at some of those photographs. But having a team is really important, and go around the hospital trying to help improve care as a team, visible to the colleagues, visible to the trust management, I think has been really important. And obviously the team evolves over time. Here we are working very hard, but that team has stayed together and has really helped to bring focus to what we're trying to do. The next person I wanted to hear from is someone who's helped us get off the ground with our quality improvement project at the hospital that I work in. And John Crampton was the Executive Medical Director back in 2012, 2013, when we started bringing the Global Trachea Collaborative into our trust to try and improve care. And John offers his insights in the next sort of virtual interview over what he thinks a medical director can bring to quality improvement.
One of the important things we have to consider as medical director really is how we can impact the organisation positively as a medical member of the executive team and the board. And obviously we spend a lot of time thinking about how we might maximise health outcomes and reduce harm. One of the important things as well is looking at our productivity and reducing variation in care. There are obviously a number of drivers for quality improvement, which then arise down to technological change. We also have clinical research which can inform decisions about healthcare. We've also got cultural aspects as well to consider, and that's a really hugely important thing in terms of what the medical director can do. It is very important that the medical director does create a culture of improvement and gives colleagues both the inspiration but also the tools to do the job. And this actually means, I think, improvement methodology training being available, but also giving colleagues the sense that they can do things to improve care and get rid of that inertia that sometimes influences healthcare in the NHS and the UK. And it's a case of embedding that in the culture of the organisation, but also both personally and as a board, inspiring a new vision of what the NHS can really be and how it can deliver improvements in healthcare. And one of the attractions of the Global Tracheostomy Project obviously was that some simple ideas that were very clear for patient improvement care could be articulated and cascaded throughout the organisation to actually improve care, reduce harms, and reduce and improve the quality of the care that the patients with tracheostomies deserve. So clearly with quality improvement it's absolutely essential to get board level support for this type of work, so that colleagues who are trying to do the work to improve quality feel enabled and feel they have the authority and the resources to carry out that improvement work on patients. And when cascading the work to other colleagues within the organisation, that they feel that the board is both wanting to see the project through, but also to monitor its progress, and has continued an active interest in seeing the quality improvement carry through to its completion.
So just to pick up on some of the things that John brought up there, so we make it a real key thread of signing organisation up to the GTC to get that executive level support, and it's really important. And John mentioned there a few things about resource provision. So you know, if we need to get something done, if that's time or if that's some equipment or even just encouragement to get things going, such as a tracheostomy ward round, having that provision from resource within the organisation is absolutely critical. The trust can also help you with motivation and staff engagement. So, for example, tracheostomy care may not be on the trust's radar as something that's important to the organisation. But if it gets fed down from the top that actually this is really important, and that they're expecting frontline staff to engage and to be motivated to improve care, particularly around something that you're trying to do, then that again is a really powerful enabler. Having that organisational support will help sort of push the message, will help tap into their internal comms, for example. Monitoring progress is key as well, and I think you can look at that from an executive level, but also from the people running the project, and certainly from talking to people like John and people responsible for managing your organisations. People with good ideas sometimes go off on a little bit of a tangent, and having a sort of set of goals that you agree with your organisation, that you'll report your progress, and it makes you reflect on your progress and keeps you on task. And so John asked us to report to our hospital board every 6 months during our tracheostomy improvement project, which made us think about reporting, think about what we're going to do, steps along the way. We used the GTC reports that were generated, which you will have access to as a GTC hospital, to show the trust what we were doing, what progress we were making, and what our plans were. And key elements of some of the things we were trying to do were things like trying to get mandatory training for staff members on the front line with tracheostomy care, and the trust support in making that mandatory and supporting us doing that, again, was absolutely critical. From a practical level, when you're trying to change things from the ground up, if your hospital is anything like the ones that I know or the ones I work in the NHS, there's a lot of layers that you've got to get through in order to get somewhere, a lot of ceilings you need to break through. And if the organisation has said from the top, no, we support this, and that support comes down through those layers, that is, again, a very powerful enabler that John alluded to. So instead of having to go through infinite layers of middle management, which you have to sometimes, just say, no, the executive board support this. This is what we're going to do, can really save you an awful lot of time as someone on the ground. But the other people that are desperately important in all this are the users. And I like telling an anecdote about spending 6 months trying to decide what bronchoscope to have on the ICU or available for tracheostomy care. And you ask the patients, they really couldn't care less. They want to know, why can't I eat? Why can't I speak? When am I getting this thing out of my neck? When am I going to get out of here? And so asking patients what's important to them is absolutely critical. And that's something, again, that the GTC focuses on and makes sure that patients and carers are at the heart of everything that we do in the GTC. There are some studies about using patient feedback in trying to improve patient safety, and I've put up a few references here again, and thank Professor Bion for lending me these slides. There's a number of studies that have showed that you can have an impact on the safety and the quality of care in wards that genuinely value patient safety and patient safety feedback. And this is an example of a program in the United Kingdom using active patient involvement in ward level meetings. Patients were reporting problems that they saw, and then they were being invited to be part of the solution. And although this wasn't statistically significant, it did show that there was an improvement in safety as measured by this patient safety thermometer tool that we use in the NHS. Some of those barriers, though, to incorporating patient feedback are quite interesting. And again, this has been looked at by various authors, and I think this one study stands out that, you know, most areas are receptive to using patient feedback and the patient experience, but some wards, whilst appearing to welcome patient feedback, actually still have that attitude that no, we know best, we don't need to listen to what the patients are telling us. And the number of wards are actually hostile and defensive to any suggestions or any potential interventions from patients, and clearly that's a big potential barrier to change. There are various ways, again, of trying to get around that, but trying to understand some of those influences. You know, the people who are pushing back when it comes to patient feedback and patient involvement, you know, that they're not generally trying to stop improvements in care, that they're not valuing that input, but there are all these things that you need to try and understand about why people might give you pushback when you're trying to directly involve patients. And again, there's plenty of people within the GTC who have experience of incorporating patients directly into some of the work that we're trying to do. This is Bob Sutcliffe, and Bob was our patient champion at our hospital until he sadly passed away relatively recently. And Bob and his wife Christine inputted a lot into our care at Wythenshawe. Bob was a patient on our intensive care unit for a very long time, and then spent a lot of time touring our hospital wards, unfortunately, as well, until he was well enough to go home. And Bob said a few pretty profound things while he was with us, and he agreed to be our patient champion. And I'll show you a little guest virtual interview with Bob and his wife in a moment. But one of the things that resonated with me from talking to Bob was that he was in hospital and out of hospital and back in hospital again a number of times around the time we were starting to try and get our act together on our hospital wards. And Bob said to us when he went back to one of our wards in the hospital, he was pretty apprehensive about going because he'd not had great experiences there in the past before. And one of the things he said to us was that he was really relieved when he first got to this ward to be welcomed by staff that were knowledgeable, clearly competent around tracheostomy care. He was instantly relaxed, and he described it as being completely different to his previous experiences, like being in a different hospital altogether. And that was just through us training staff, making sure that staff were equipped, competent, knowledgeable to deal with tracheostomy care. And for Bob, as an experienced tracheostomy patient, for him to be able to tell us he was so relieved and relaxed because of this improvement in care that he could detect was a really nice thing to hear and very rewarding. So we asked Bob a few other questions, and here's an interview with Bob and his wife Christine, picking up on a few things that patients tell us that are important about improving tracheostomy care.
To begin with, I can't remember too much. When they asked me, do you know why you're in hospital, do you know why? And I'm saying yes, I didn't really. But as the weeks rolled on, to realise just how ill I was.
The most stressful part, I suppose, was being told they had to have a tracheostomy. I just wondered, very selfishly, how I would cope with that. And I felt sad for Bob because that's the one thing he didn't want.
Oh yes, when I was a boy out, I used to drink the water, and I was either in water in a submarine, in David Beckham's submarine with his kids, and also in a yacht belonging to someone else. It was always in water. I seem to remember all the time. I remember the bluebirds floating around, and they all disappeared in the pipes. And so, worst thing in the world, nothing ever came good. It was soul destroying when you see somebody else eating and drinking and you can't. Not very nice. I hated really that. And that was one of the things that really was the worst thing, I think, is not being able to eat and drink. And it was was so happy when I could reach up long enough.
Yes, we got a lot of help really, and a lot of guidance.
Yeah.
As I said before, I think I was worried about having to deal with tracheostomy, what I would have to do. But the nurses and everyone on ICU showed me each time it came how to clean the tubes and how I would bathe round. And so that was all right, and we got a lot of help from.
There were some nurses from traffic that came around as well.
Yes, there were. And I think
so the support was there.
Yeah, I think we got quite a lot.
Fine. I wish I hadn't got it, but you have to live with it. And now I'm off the ventilator at night. That makes me happy.
So that was Bob just highlighting some of those problems and issues that patients have, and you'll hear Bob there just talking about the problems he's had eating, drinking, feeling dehydrated, and that sense of frustration when someone else is able to eat and drink and he couldn't. And we've been fortunate to speak to lots of patients who tell us very similar things, and there's videos from Professor Stephen Hawking on our website when he spoke at our one of our launch meetings in the UK, who said exactly the same. So it doesn't matter who the patient is, that the insights that patients can offer about what's important to them, what we should be trying to do is really important. Bob also mentioned about delirium and confusion and communication on the ICU. He told a fascinating story there about thinking using David Beckham's submarine, and David Beckham's sort of famous footballer celebrity that we've got over here, if you're not familiar with him. I've got a list of the drugs that Bob was taking in our ICU, if anyone fancies a trip to David Beckham's submarine, so you'll have to just email me for that one. Okay, so moving on to what we understand about trying to improve quality at a national level, and again we're leaning on existing published quality improvement collaboratives and things that we can learn from. And on the screen there's a list of mainly intensive care based QI collaboratives that will be familiar to some of you, I'm sure. And lots of people out there have been doing similar things, and again within the GTC there's plenty of experience of people who've done this successfully, who can help you if you need help getting some of this stuff sorted out in your hospital. Understanding the context of the improvements that you're trying to make is again critically important, and we'll put the links up to some of this work, but Professor Mary Dixon Woods has done a lot of work on behalf of the Health Foundation in the UK, who fund a lot of our work in trying to understand how to make changes happen. And a lot of this looks at when we've taken successful QI collaboratives from other centres, other countries, and tried to implement them into the NHS, what things work well and what things don't work well. And all of these papers that are on the screen there provide real valuable learning to save you having to go through that experience yourself. One of the things that try to understand why we could have an impact from joining quality improvement collaboratives came from understanding that it wasn't just about a checklist. So it's not about going to a patient's bedside and checking that they've got a spare tube or checking that the suction works. It's more than that, and that goes back to that sort of social signalling and sort of changing what you're doing. The clinical community in the Keystone Matching Michigan Central Line project became more of a learning community where people were learning from each other. There was momentum from within the collaborative itself, strong leadership, but then peer pressure to succeed, and a real social network that sort of sprung up. It was more of a social problem than just a technical problem, so it wasn't just about a checklist, it was about culture change. Some of those functions, as I said, so with the central line program, it was about making sure that people were doing all the right things, all those elements brought together, and signalling that you were there to improve care and to make things better. We can do the same with our tracheostomy care. And as the program rolled on, it became gradually more participant-led rather than led by a sort of group of so-called experts. And I think you'll find that within the GTC. It's not a case of me or anyone else telling you what to do. It's about finding a forum for us to share our experiences and to try and improve care and improve what we're doing, but led by you guys, not led by GTC Central by any means. Interestingly, trying to find evidence for whether this occurred or not is quite difficult, but there's certainly plenty of stuff out there which is really useful. When you look at some of that work that the Health Foundation provide, we can see the sort of things that we learned certainly in the UK, which I'm sure are applicable to other parts of the world, giving responsibility for delivering the project not to executives but to the people on the ground, and supporting those clinicians and managers doing that role was vitally important. And then involving those patients who are using the service, so tracheostomy patients and their families and carers, agreeing on the metrics. So I'll show you some metrics that we've collected from our hospital in a moment, but there are lots of metrics you can use around tracheostomy care, but choosing the ones that are meaningful to you in your organisation, the ones that allow us to benchmark individual sort of process metrics, but also system-wide metrics as well. Technical interventions, behavioural change interventions, how to reach those people who aren't bothered, who aren't engaged in your project. Again, there's plenty of information out there on strategies to try and engage some of those people. And then understanding the context. So, you know, if I take an idea from a hospital in Melbourne and try and drop it into Manchester, it might work fine, but it might not. And trying to understand why it works in one centre rather than another is really quite important. So I want to turn our attention to how we can try and influence care and quality improvement internationally. And this is, I think, where the collaborative comes in. This is where we're up to as things stand currently with the Global Tracheostomy Collaborative. So way back in sort of 2009, 2012, we had a number of reports coming out from different countries, and I've highlighted just a few of them there, that gave us an understanding of what the problem was, trying to put some metrics and some numbers onto the scale of the problem and what the issues were with tracheostomy care. And we tried to turn anecdote into meaningful research that we could understand and sort of get to grips with. And what we did with the GTC was take these little jigsaw pieces where people had shown improvements in care by standardising things, by bringing a multidisciplinary team together, by getting patient and family input and staff education, and bring those elements together into the Global Tracheostomy Collaborative. And that all started around 2012. What the collaborative does is give you a database where you can track individual patient level metrics, and I'll show you some of the data that we can get out of these databases. And following a series of launch events, we ended up with about 30 sites putting data into that database, which we feed back to sites. And if you're a member, then you'll have some of this data to hand. What we've done in the UK in some detail is trying to look at that contextual quality improvement and try and understand how we make changes. A lot of that's very obviously relevant to the UK, but some of that will be relevant to centres outside the UK as well. And we've moved from that pilot data in the UK to having 20 sites involved in now a detailed large-scale demonstration programme that we're hoping to show we can improve care, but also improve the quality of care as well as the safety of care. And we think we can save a significant amount of money through better care. But what we're trying to do is understand how we improve care around tracheostomies, how we engage those multidisciplinary teams, how we bring people together. And the GTC has now grown to over 50 sites around the world. And again, each step along the way, we're building on this knowledge. So by putting it all together, we've started to produce reports now from the impact that the GTC can have, and we've just published this in the last couple of weeks from that initial pilot project that we did in South Manchester. And I'll just pick out some of the highlights from that paper. As you can see from the timeline at the bottom, we didn't do everything all at once, and this is typical of trying to get quality improvements started in any hospital. And it took some hospitals several months to get on board. This is 4 hospitals working pretty closely together. So we didn't start everything all at once. We didn't do all the interventions at all the sites. And this would be typical if you look at all hospitals in the GTC about what people are doing, how long it takes people to get going. Well, you can see that we started planning our steering committee meetings after a couple of months. We did a staff survey to understand what the problems were. We got patients involved. And then we started our ward round 8 months into the project. At the end of the project, within 12 months, we were able to look back at data from over 300 patients that we'd admitted with new tracheostomies to the 4 sites that were participating in this detailed programme. And we were able to demonstrate we had a significant impact on the severity of harm that resulted from patient safety incidents. We didn't eliminate incidents, and interestingly, the rate of incidents didn't really change. But I think that's partly because people knew that we were participating in a project, people were reporting things that they perhaps hadn't reported before. But the impact of the severity and the level of harm that was arising from those incidents certainly went down. And that was one of the key goals of our project, to make care safer. But we're interested in, could we influence the quality of care as well? And as Bob and other patients have told us and told you this evening, vocalization and communication is a key part of what patients want to do. And we set ourselves a goal of reducing the time it took from patients having a new tracheostomy to having a speaking valve used for the first time, which meant they had to progress if they were on the intensive care unit to having their cuff down, for example, but then having a speaking valve fitted and attempts at vocalization. And again, we're able to show a significant reduction just in 12 months by thinking about what we're doing, involving the right people, by bringing that MDT together and making vocalization and communication a priority for our tracheostomy patients. And that's just one example of something we drilled down and looked a lot of detail at what we were doing with our tracheostomy care. And all that stacked up into reducing the total time patients had a tracheostomy tube in situ for. So we were decannulating patients nearly a day quicker than we had been at the start of the project, and that translated into reduction in total hospital length of stay for our patients who were admitted and had a new tracheostomy. That meant reduced intensive care length of stay and reduced ward length of stay, which had a significant cost impact. I haven't put the cost figures up, but the money we saved for 300 patients or so in that 12 months was around £450,000 on a very crude estimate, just based on length of stay. So when you add in consumables, you add in the cost of readmitting patients to hospital, perhaps if we hadn't got the care right, that number is bound to be bigger. And the current project is looking at a detailed economic analysis that we can make a strong case that the GTC is an absolute bargain. Trying to understand the context and the ethnography of what we're trying to do is what we're doing with these 20 sites currently in the UK, and we've got similar ideas to do similar things in the other continents represented by the GTC. And this is one of the meetings that we had of our 20 sites, where leaders in those sites in the UK came together down at the Royal College of Anaesthetists in London, who hosted a day for us, to try and understand what our priorities should be and what goals we should be trying to achieve as we try and improve patient care. And this example of one of the things we did where we agreed what was important, what we were going to focus on, whether we were doing it already, whether we were planning to do it, and we used this to construct a to-do list, if you like, that was constructed by our member hospitals that we can support then as a sort of lead team in making sure that hospitals are setting off, trying to improve things that they want to improve, that they think there's a good chance that they'll be able to achieve. So, trying to bring this all together then, how do you get a QI collaborative working in your unit, in your hospital, in your country? So you need to start with enthusiasts, and I think the first wave of hospitals and members that join the GTC are certainly enthusiasts, and we're delighted to have you on board. I think the people who've joined the GTC so far are going to be shown to be leaders in the way that we've tried to improve care. But don't forget the people who are a little bit cynical about whether we can actually achieve our goals, and they're important people to bring on board. And I think it's healthy to have people sort of questioning what we're doing and to feed back areas where we could perhaps divert some of our attention and some of our energy. You'll find that within your unit, you'll find that within your hospital, and you'll certainly find that in countries and sort of cities around the world. We need to understand what the problems are in your site, in your unit, in your country, who's going to own it, who's going to lead change, and that can be on the ground and it can be a sort of system-wide problem. Characterise what you're trying to do, which is always difficult, but there's plenty of help out there from sort of program theory and from some of these QI resources, but also the experience of the collaborative and others around there, and resources that exist that we can help you find. And the sort of goal of trying to change people's attitudes and behaviours and performance is to try and normalise best practice. So make great tracheostomy care what you do as part of the work in your hospital. It's always good to sit down and reflect on what you're doing, and that can be brought about through receiving the reports from the GTC, or as our medical director said, making a sort of agreement or a contract that you'll report back locally to your hospital as well as perhaps externally, and benchmarking yourselves so that you know where the problems are, you know what success looks like. And something that we're going to be exploring more as the collaborative grows and as we get more patients in the database is research to understand what works well in what sort of contexts. So I think it's quite an exciting time really for tracheostomy quality improvement. So thank you for listening to this webinar. There's a couple of acknowledgements that I'd like to make before I just turn my attention to one or two of the questions that have been coming in. So thank you to the team at South Manchester who've contributed resources to the webinar, particularly James for his time and interview, John Crampton as well for giving up some time to help us with the video, but also for his support in getting this project up and running. You've heard from Bob, our former patient champion, and his wife Christine, and again thanks to Professor Bjorn for lending me a few slides for his support along with the Health Foundation in understanding and supporting us understanding some of those contextual differences in the UK. The Royal College of Anaesthetists have supported our work and supported our research programme aligned with improving care in this country, but also the members of the teams of the GTC for asking us to lay on this webinar, for providing us the support, the information and some of the resources that we've used as part of this collaborative. There's been a few questions coming in from Twitter, and there were a few questions posted before this webinar, and I think most of them could be summarised by how do I make this work in our hospital. And I hope that some of the things that we've brought up throughout this webinar will, if not answer your question, certainly put you in the right direction. And I'd like to sort of draw you back to the GTC website, where there'll be forums where we can discuss any of the fallout from this webinar, and the resources and references from the webinar will be made available. That if you want to take some of the presentation, if you want to take some of those references that we brought to your attention, please do share the links, and please do be active on the forum and tweet and talk to each other and talk to us about them. But finally, don't forget that we're all a resource for each other, and so the members of the collaborative are, there to help you. And if you have success, if you have experience of success at making things happen in your hospital, we'd love to hear from you. If you have problems, again, we can put you in touch with other people in the collaborative who perhaps have got a good idea on how to make something happen. So thank you for listening. Please check in with the GTC website and the forums for the follow-up to this webinar. So good evening if you're in the US, good night if you're in the UK, and get to work if you're in Australasia. Have a good day, everyone. Thanks very much.